Hi everyone, my name is Ainsley Johnson. I am really excited to be a part of the first education week that we are having as a part of the college, and I would like to thank the organizers and everyone that brought us to where we are. I would just like to quickly introduce myself for those who don't know me. I am a generalist sonographer and I have been working at the IWK Health Center for 3 years. I graduated from Dalhousie University in 2019 with a Bachelor of Science in Economics and a Bachelor of Health Science in Diagnostic Medical Ultrasound. Working in a pediatric hospital has enabled me to learn things from a different point of view and to see pathologies that I wouldn't otherwise. While this presentation centers around a pediatric case study, adrenal rest tumors are also prevalent in adults with congenital adrenal hyperplasia. So I hope everyone can take something from this presentation. To start off, I'm going to review a short case study with ultrasound images. Then I will dive into a little bit about congenital adrenal hyperplasia and the theories about the origin of adrenal rest tumors. I will then expand a little more on the prenatal sonographic findings associated with congenital adrenal hyperplasia. Finally, I will discuss adrenal rest tumors in the testicles, ovaries, and other more rare locations along with the sonographic characteristics of these tumors. Our case study is a 13-year-old male with the salt-wasting type of congenital adrenal hyperplasia. I will explain a little more as to what this means later in this presentation. What is important to know at this point is that the patient was not totally compliant with his medication, so the disease was suboptimally controlled. The endocrinologist wanted to know if there was any evidence of testicular adrenal rest tumors. Immediately by looking at this image, we can recognize that these are not the homogeneous testicles that we are used to seeing. There are hypoechoic areas bilaterally. Starting with the right testicle, we can see this irregular hypoechoic area surrounds a more echogenic portion, which is the mediastinum testis. This mass is well vascularized, as is the rest of the testicle. Here we can see the hypoechoic region extends along the entirety of the mediastinum testis. The mass measures 2.5 by 1.3 by 0.9 centimeters. Moving on to the left testicle, we can see a very similar area in the same location. It is similar in size to the right side, measuring 3 by 1.2 by 0.9 centimeters. We can see that there's good arterial flow in the testicle. We can also see from the color Doppler that the mass is also well vascularized, and perhaps slightly differently from the rest of the testicle. On the left epididymal head, we can see a well-defined hypoechoic round mass. This mass is also well vascularized, peripherally and centrally. The mass measures less than 9 millimeters in diameter. This patient also had bilateral varicoceles, although I have only included images from the left side, as the varicosities on the left side were more prominent than they were on the right. Also on the left side, the veins did not change in size with the Valsalva maneuver. A quick exam of the abdomen was performed due to the large varicocele on the left side to ensure there was no mass on the kidney or other extrinsic pressure on the venous system. There were no obvious masses, but we can see from this image of the left upper quadrant that the adrenal gland was quite large, which goes along with the patient's condition. In this age group, we would typically not see the adrenal gland at all. The final report stated that there were bilateral hypoechoic areas adjacent to the testicular hyla with slightly more vascularity than the normal testicular parenchyma. These are thought to represent testicular adrenal remnants or adrenal rest tumors. The radiologist also reported that there were bilateral varicoceles and a solid hypoechoic nodule in the left epididymis of unknown origin. Before I dive into information about adrenal remnants or adrenal rest tumors, I'm going to give some information about congenital adrenal hyperplasia and how it leads to these tumors. Congenital adrenal hyperplasia is a disease with an autosomal recessive inheritance pattern. It occurs in about 1 in 15,000 births. The classic type, which makes up about 90% of CAH cases, is caused by a deficiency in the CYP21 enzyme. This deficiency results in impaired production of aldosterone and cortisol. The cortisol deficiency results in a negative feedback loop in which there is an increase in production of adrenocorticotropic hormone. Subsequent hypertrophy of the adrenal glands and an increase in adrenal androgens also occurs. There are two subtypes of the classical type. The first is the salt-wasting type, as our patient had. This means that the body is unable to make enough aldosterone to retain sodium, and therefore there is too much sodium lost in the urine. This is life-threatening if not treated, which makes early diagnosis very crucial. The second type is the simple viralizing type, which is less severe as it does not have the salt-wasting effect, but results in increased androgens and thus masculinizing effects. This slide lists the viralizing symptoms of congenital adrenal hyperplasia. The main signs that occur at birth or prenatally occur mainly in females. This is because in males, the main source of testosterone is from the testes and not from the adrenal glands. Therefore, there is not much effect on the genitalia early on. This makes initial diagnosis difficult in males, which is particularly life-threatening in the salt-wasting forms of the disease, as quick diagnosis is required to avoid the dangerous effects of salt elimination. At birth, some males have genital hyperpigmentation or penile enlargement, but these can be less obvious or not present. Luckily, most countries have a screening program in neonates for congenital adrenal hyperplasia to ensure a quick diagnosis. The ambiguous genitalia in females exists on a spectrum, with one side of the spectrum having mild clitoromegaly and the other side resulting in a full labial fusion with a common urogenital sinus in place of a separate urethra and vagina. I will show a diagram showing this spectrum after this slide. The internal reproductive organs will appear as expected in a female neonate. The rest of the viralizing symptoms occur in childhood and early adulthood. These symptoms include precocious puberty, clitoral or penile enlargement, precocious pubic hair, hirsutism, acne, reduced fertility, menstrual abnormalities, and small testes. This diagram shows the Prater scale for female ambiguous genitalia. On the far left, we can see typical appearing female genitalia. As we go along, we can see increasing clitoromegaly, increasing labial fusion, and in the last couple of images, we can see what is described as scrotalization of the labia. In the stage 5 image, we can see that the internal anatomy is slightly different as the urethra and vaginal canal come together and form a common urogenital sinus. As for the salt-wasting symptoms, these will occur very quickly in the undiagnosed and untreated infant, often within the first few days of life. These include lethargy, poor feeding, weight loss, signs of dehydration, hypovolemic shock, convulsions, and death. These can also occur later in life if treatment is discontinued, so it is very important for these patients to keep up with their medication. Here I just have a couple of images of prenatal sonographic findings of congenital adrenal hyperplasia. This first slide shows ambiguous genitalia in a female fetus. During the first trimester scan, the nuchal translucency was mildly increased. The patient opted to have an amniocentesis, which confirmed a normal karyotype and 2 X chromosomes. You can see in both the 2D and 3D images the enlarged clitoris and the surrounding labia that was detected at 29 weeks. At this time, there were also hypertrophic adrenal glands that appeared large and discoid rather than triangular in shape. A sample of amniotic fluid was obtained and confirmed the diagnosis of congenital adrenal hyperplasia. The mother was treated with steroid therapy until birth, after which the baby received appropriate treatment. These images show an example of adrenal hypertrophy in a fetus. You can also see that the cortex is hypoechoic compared to a normal adrenal gland in a fetus. This sign is important to look out for, as in males they will typically have normal appearing genitalia on ultrasound, so this will be the only sign. Now I'm going to discuss where adrenal rest tumors come into the picture. Adrenal rest tissue is simply ectopic adrenal tissue. This tissue usually only consists of adrenal cortical cells with no medullary tissue. There are two main hypotheses as to why ectopic adrenal tissue occurs. The first theory being that the adrenal rest tissue occurs in embryology with gonadal descent. I'll show this to you on the next slide. The second theory is that it comes from cell differentiation in the testicular hilum in cases of testicular adrenal rest tumors. The thought is that testicular hilar pluripotent cells differentiate as a result of increased adrenocorticotropic hormone levels. Some animal studies have supported this theory. In these studies, male pups with adrenal aplasia can survive due to adrenal-like cells in the testes that produce glucocorticoids, while the female pups die. This diagram is a little refresher on embryology of the kidneys, gonad, and adrenal glands. As you can see, the adrenal glands, the small yellow circles, are in their typical location. The large undifferentiated gonadal ridge, which is in the blue, is initially extending from the upper abdomen to the pelvis. As the gonad descends and decreases in size, the theory is that some adrenocortical tissue adheres to the gonad and descends with it. The theory is supported by incidental findings of ectopic adrenal remnants that are found along the spermatic cord. Testicular adrenal remnants are the most common type of adrenal rest tumors. Testicular adrenal rest tumors are the result of hyperplasia of ectopic adrenal tissue within the testes. These tumors are more prevalent in the salt-wasting type of congenital adrenal hyperplasia. TARTs affect anywhere from 14 to 95% of males with CAH. Sometimes the first symptoms are testicular related. Infertility, discomfort, or palpable mass might be felt. These are almost always benign tumors. However, they can cause damage to the testicles and have a negative effect on fertility through compression of the seminiferous tubules. There is also some research right now that suggests these tumors may also have toxic effects on the surrounding testicular system because of the hormonal function of these masses. On ultrasound, testicular adrenal rest tumors are typically hypoechoic. They may be homogeneous or heterogeneous in echotexture. They are almost always bilateral, and there may be multiple masses on each side. The borders are usually well defined, and they can be round or lobular. They are usually seen around the mediastinum testes. The vascularization is not a helpful characteristic, as they can vary from being very hypervascular to having no flow detected on ultrasound. Usually, if a patient is diagnosed with congenital adrenal hyperplasia and has masses like these in their testicles visualized on ultrasound, this is diagnostic. Following with ultrasound is recommended. The masses will also decrease in size with steroid therapy. This is an example of classic appearing TARTs. They are more hypoechoic and rounded. While TARTs are typically hypoechoic, these are examples of hyperechoic adrenal rest tumors. They are also more oblong rather than round. This patient had multiple testicular adrenal rest tumors, but these lesions appeared avascular on ultrasound. The differential diagnoses for testicular adrenal rest tumors are Leydig cell tumors and malignant testicular tumors. However, these tend to be unilateral, located anywhere in the testicle rather than mostly at the hilum, and they also tend to have mixed echogenicity. Testicular adrenal rest tumors are typically diagnosed with ultrasound and can sometimes be diagnosed with other diagnostic imaging. They can also be diagnosed with a biopsy or post-surgically by pathology. However, pathological confirmation is not usually necessary for these tumors if they exhibit the typical sonographic characteristics and the patient has congenital adrenal hyperplasia. Ultrasound is also used to monitor the size of adrenal rest tumors. These images came from a case study published in 2010. The patient was a 26-year-old male with the salt-wasting form of congenital adrenal hyperplasia. In his adolescence, he became less adherent to his medications. He didn't have any follow-up again until he was in his 20s, when he was investigated for infertility. Semen analysis showed azoospermia. A testicular ultrasound showed multiple bilateral testicular adrenal rest tumors, which you can see in one testicle in the left-hand image. The right-hand image was taken 13 months later after an adjustment in hormone therapy, and the tumors on both sides had completely regressed. Luckily, fertility was restored, and the patient's wife became pregnant within months of adjusted therapy. Adrenal rest tumors in females are very rare. Ovarian, paraovarian, and adnexal adrenal rest tumors have been documented, but there are very few cases in the literature. Researchers suggest that there is a low incidence of these masses in females because there is primary sex cord regression in females. In embryology of males, the primary sex cord forms the reedy testes and the seminiferous tubules, but this has no role in females, so it regresses, and presumably the ectopic adrenal cells would also regress. However, one study looked at 3 women with congenital adrenal hyperplasia that was unresponsive to hormone replacement therapy. There were no diagnostic findings of pelvic masses on MRI or ultrasound in these patients. All 3 women had small OARTs on laparoscopy and confirmed by histology. One patient improved significantly post-operatively with her hormone levels returning to normal, a decrease in the adrenal hyperplasia, and she continued to develop female sex characteristics with the reduced hormone therapy. In the other patients, a unilateral adrenalectomy was recommended. This was the only confirmed ultrasound image of an ovarian adrenal rest tumor I could find. The case study, published by Tiazano et al. In 2010, was an 18-year-old female who was diagnosed with congenital adrenal hyperplasia at birth. She had severe hirsutism and other viralizing effects throughout her childhood. She underwent an adrenalectomy at age 10. She began normal puberty shortly after this and had reduced hirsutism. Then, hyperpigmentation and hirsutism reappeared 1 year after surgery. Her testosterone levels had increased, but there were no significant findings on MRI or ultrasound. At age 18, the patient returned with extreme viralization. Transrectal ultrasound revealed this mass on the right ovary. The patient had a laparoscopic removal of the ovarian mass. 1 day after surgery, testosterone levels decreased significantly. Unfortunately, there are no set criteria for sonographic appearance of OARTs, as these have been so rarely documented. The article stated this solid mass had apparent vascularity on color Doppler interrogation, but no other information about sonographic appearance. Adrenal rest tissue can also be found in other locations. Some more common locations are around the celiac axis and the broad ligament of the uterus. Other locations of adrenal rest that have been documented include the liver, lung, brain, pancreas, omentum, transverse colon, and the epididymides. They are usually less than 7 millimeters and incidentally detected on surgery or autopsy in both patients with congenital adrenal hyperplasia and no hormonal abnormalities. I found a case study on a rare adrenal rest tumor located in the liver. The study by Shin, published in 2010, was on a 62-year-old man who had a regular checkup during which a hepatic mass was detected on ultrasound. The mass was a 3 centimeter heterogeneous solid lesion at the posterior periphery of the right lobe. The patient went on to have a CT scan, and hepatocellular carcinoma was suspected based on this scan. The patient went to surgery and had this segment of the liver removed. The mass appeared to be directly adjacent to the right adrenal gland. However, there were no abnormalities of the adrenal gland or evidence that it was adherent to the liver. This was sent to pathology, where they determined with microscopic studies that the mass consisted of adrenal cortical cells. There are a few distinct radiologic characteristics of hepatic adrenal rest tumors. There is almost always a fatty component detected. However, this was not evident in the case study, which made pre-surgical diagnosis difficult. These masses also tend to be hypervascular and may contain foci of calcifications. I have one more case study to share with you here. This is a 15-year-old male with congenital adrenal hyperplasia who complied well with his medication until he was about 14 years old. He had yearly testicular ultrasounds and regular biochemical testing. His hormonal and metabolic control was adequate until adolescence. He had normal annual ultrasounds until he was 15. At this time, his physical exam was normal, but the ultrasound showed multiple homogeneous, hypoechoic, hypervascular masses in both testes, all measuring less than 1 centimeter. Bilateral lesions were also found in the epididymal heads bilaterally. These lesions exhibited the same sonographic characteristics as the other lesions. You can see here they also used strain elastography, which demonstrated higher stiffness in all lesions compared to the surrounding testicular parenchyma. After 6 months of compliance with glucocorticoid therapy, the epididymal and testicular lesions decreased in size, with some testicular lesions completely regressing. While we cannot be sure that the epididymal nodule in our original case study was an adrenal rest tumor, there is evidence of epididymal rest tumors in the literature, although this was the first one documented in the literature, but it still is a possibility. I would like to wrap up with a few key points. Adrenal rest tumors are ectopic adrenocortical tissue. In congenital adrenal hyperplasia, the ectopic tissues exhibit hyperplasia the way the adrenal glands do. There are two main theories as to why adrenal rest tumors occur. The first is embryologic. The thought is that the adrenal tissue adheres to the gonad during gonadal descent. The other theory is that the pathway is through pluripotent cell differentiation. These types of masses are most commonly found in the testicles. On ultrasound, testicular adrenal rest tumors are almost always bilateral, and there can be multiple occurring in each testicle. They will usually appear hypoechoic and are located near the mediastinum testis. The vascularity in these lesions are variable. With regular follow-up and compliance with hormone replacement therapy, these tumors should regress. Adrenal rest tumors can also occur in females in the paraovarian and ovarian regions. There are not many cases of these documented in the literature, although one study suggests that they may often be too small to detect with diagnostic imaging. There are also a few rarely documented cases of adrenal rest tumors occurring in the epididymides, the brain, pancreas, liver, lungs, omentum, and colon. And these are my references. All right, I'd like to thank everyone for listening to my presentation. If you have any questions about this talk, feel free to email me at the email listed here.